Hi, everybody.
Hi there.
Welcome, welcome. It's 12:30, but we'll just give people a couple more minutes. Kira, how many more are registered that we need to wait?
Registered, there's about 5 or 6 more, but again,
Okay.
I think that if we just give it a couple more minutes, usually sometimes people kind of drip in when they can.
Yeah. Great. I'll give it until my laptop says 33, and then I'll start. Yeah. Okay, I'll start, and then as people join, then they can just pick it up as and when they're able to come in. So for those of you, I think I know most of you, if not all of you, at least I've met online, if not in person. My name's Ruth Taylor, and I'm the interim chief exec of the GPSU. And we've set up this series of drop-in lunchtime sessions as part of our efforts to start to reach out and communicate with practices and start to answer the question, who on earth is the GPSU? What have they ever done for me? And what are you planning on doing? Because I think that's what we're hearing more and more, really. We're a bit of an unknown entity at the moment. We are still technically registered as Somerset Primary Healthcare, SPH, which is the organisation owned by all practices. So all of you in practice land are shareholders of SPH, now known as the GPSU, the General Practice Support Unit. And I think that's a really important fundamental sort of ethos for us as an organisation, that we are here in principle to serve practices and to do what needs to be done that's going to add the most value and impact to general practice. And that's the refocus that we've been going through over the past 6-9 months. We have been born out of SPH. The board determined that some refocus was needed. Were replaced by an interim board. So there's been an interim board with an interim chief exec. The substantive board was appointed earlier on this year. I'm still in an interim role, but there's a process about to be launched to secure a substantive chief exec. So we're really in the process of transformation ourselves and looking very, our real focus is around what can we be doing to add value to shareholders and to enable general practice in Somerset to thrive. So that's what we are all about. And we have got some legacy work that SPH was already doing that we're continuing to build on, some staff that were part of SPH who are really core valued members of the team now. But as we're starting to look forwards a bit more, we're needing to put in place some infrastructure, some HR and finance infrastructure, have an established team that can lead the transformation and the development, with this main focus being on general practice. So we are ourselves going through some change, and we feel at the moment as though we're a fairly small startup team, but really keen to make sure that even though we are small and just really getting going, we want to keep connected to general practice. Hence the fact we've started the fortnightly bulletin. We're putting in place these monthly drop-ins. We're starting to have facilitate events and conversations in various parts of Somerset to explore what the neighbourhood working could look like for us in general practice. So really important, lots of change, but the focus is on general practice. We're in the process of building our own infrastructure. Funding, we have been in the really privileged place of having had some pump priming funding that came through from the ICB last year, and a commitment that they will give us some core funding for 3 years. We're in the first year of that committed core funding, so with another 2 to go. And that core funding includes some funding for clinical leadership, clinical involvement in the development of pathways and services from a general practice perspective. And that's why and how we've been able to establish the clinical reference group that Barbara, who's on the call here and can give a wave to say hi, is setting up and running. So I think that's a really important. Funding is going to be an issue because other ways of funding us have been historically through the projects that we have been funded to deliver, and that will continue to be the case as well. And like any organisation, we need to make sure that those projects that we are funded to deliver, we take some contribution for our own overheads. So our focus is on being able to articulate clearly and meaningfully what we're doing, how that's going to add value to general practice. And we're really keen to share that with you ASAP. We're planning on starting to be able to do that from the new year. But we didn't want to wait until then before we started having conversations. I think one of the important things in this changing world, when there's so much uncertainty about quite what the future looks like, that we continue to talk together and we share ideas and we share best practice. And that's why we've got some time now to hear from some work that Froome and Mendip have been doing as PCNs, and then also from South Somerset PCNs and Christoph about the conversations they've had around neighbourhood working. So I think that's the context for this conversation. I don't know if there's anything you particularly want to ask me at this point. Any questions, or shall I hand over now then to Karen and to Jenna, who are going to start to talk about some of the work that, well, Karen in particular has been doing from Froome. And is Emma here as well, or is it you? Karen, over to you.
Yeah, I'm hoping Emma's going to join us. So I think she's expecting 12:45. So she might join us now.
Oh, she's here.
She's here. Great. Okay. Well, I think the first thing to say is we weren't quite sure who the audience was going to be, as in, I know some of you will have probably been at the Tim Briggs and Claire Fuller visits, so we'll have heard some of this before, and some of you will also have been at the CD board where we talked about the pilot. So please forgive us, we haven't got a presentation. We thought we'd just give you a very brief overview and leave it for you to ask questions, if that's okay.
And Karen, just to allay some of your fears, we're recording this and the plan is to put it on TeamNet and then share the link through the bulletin. So we're hoping this can go out more widely than just to the audience that's here now.
Okay.
So thank you for your time.
No, that's absolutely fine. So hopefully everybody's aware of the PCN pilot. So Froome and Mendip were both very lucky to be chosen to be part of the pilot. So it's a national pilot with 21 other PCNs across the country. What that gives us is 10% extra staffing budget for the next 2 years to see if we can use that budget to plug the gap between demand and capacity. That's the kind of the starting premise of the pilot. The idea is that all general practice will be uplifted to this level at the end of the pilot. So we're just getting this funding a little bit earlier. What we also get as part of the pilot is we get to buddy with another PCN. We get to meet regularly in London, sort of every 3 or 4 months. And we also get to have every 6 months have a visit from Professor Tim Briggs and Claire Fuller, who are leading the programme. And they are basically tracking our progress and see where we get to. So as part of the pilot, we have to do quite regular audits of workload and what we're doing. And we also have to define our priorities. So for us, what's been really, really helpful is that we are both RUH facing PCNs. So we've got some quite big gaps in commissioning and maybe in slightly different situation to those who might be in more central Somerset. So that's been a big focus for us in what we're doing on the pilot. So we have been addressing things like continuity. It's one of the things we've both been looking at. We've been looking at mental health. We've been looking at medicine management. But I think the key thing that Emma and I both had as priorities is looking at the primary secondary care interface. So we've done what's called the red tape challenge. Do you want to talk a bit about that, Emma? So it's not just me talking.
Yeah, the red tape challenge really was for us to really highlight and make visible the work that gets shifted from secondary care to primary care, and the stuff that we're not, paid for doing properly. And that's been quite, we've done a lot of designed audit weeks that we do. In fact, we're in one now as well, aren't we? So we're on our 7th audit week that as PCNs, and particularly with the help of Gareth at Froome and our data transformation leads, have worked really, really closely with the programme board at NHS England to actually design these audit weeks from a primary care perspective, which is something that's never been done before in this way. So we do get some really as robust as possible baseline data of what this interface really looks like for us. And again, it's to highlight the funding gaps, and also the type of work that is shifted towards us and what we need to do about resolving those, highlighting and making very visible what that work is and the costs around that. One other successful thing that Karen was very good at raising was about the advice and guidance as well, wasn't it? That's come to light. What was the update on that? We've sent a letter. Well, Tim Briggs was very vocal, wasn't he? I don't know if
so advice and guidance, we've had really positive news this morning. So some of you will be noticing that you've already reached your cap for advice and guidance. So money was given to the ICB for the £20 per advice and guidance. So we ran out of that about 3 weeks ago. So we raised it at our last visit, and Tim Briggs is in the process now of making sure that the cap is lifted and we all get appropriately funded for all the advice and guidance. So just to say, if you are one of those practices, just keep doing advice and guidance as you were, and hopefully that will all be resolved very shortly. So that for me has been one of the real positives of the pilot, is that we've been able to get some really good system changes as part of it. So one of the things that we've highlighted is both for Mendip and for Froome, out of all the PCNs in the country that we're comparing ourselves with, we've got some of the highest levels of needing to do work that traditionally would be seen as secondary care, or doing unpaid work, as we could probably call it. We've taken the approach that we don't mind doing some of that work, but we do want it to be highlighted so we're paid appropriately. So as a call to action that we made at the last CD board as a result of this is Somerset Foundation Trust have got a form now that you can complete when you are doing additional work. So that might be doing your prescribing for a midwife or a podiatrist. It might be the additional work that's come back because of through advice and guidance, or failed referrals, those kind of things. So what we're trying to do is get everybody in January to submit everything that they find in January. So at the moment, SFT are finding that there's very little submission on that form. So our proposal was that we just get all of general practice in January to try and just have a dedicated month where we really make all those things really visible. So that will help. And obviously we're doing very similar things with, what's happening with the RUH.
Yeah, so, we've kind of made a really big point that if we push for this activity in January from all of you to complete those forms, which are really simple and straightforward to do, and we get the real visibility on that activity, but we want SFT to make sure they share that data with us, don't we? Because we haven't necessarily seen it in all its clarity, but it would be great if we could get a really good uptake on that. And the CD board, when we presented this, were were keen at the time, weren't they, to all get involved, and that would give us some really good visibility then.
Yeah, so we're hoping that we'll just send around some QR codes to all the practices. So the QR codes to be in the room, it's really easy to fill the form out. And we also, as part of the preparation of that January work, we'll try and get a list of all the things that might be appropriate for you to know. Because I think what both Free and Mendip have found that, you know, we do so much work with secondary care, it's business as usual for most of us. And most people haven't realised that we're not funded for a lot of what we do. So this is really about making it visible so that we can start to, when block contracts get released, maybe draw down some more funding.
Yeah, that was a really interesting insight, actually, wasn't it? Because a lot of the audit weeks that were done were based on manual tallying, and it was amazing how some of our medsecs and receptionists just felt that this work was, you know, they didn't know it, we weren't paid for. It was kind of, you know, it was a GP's job to do this, and that came out quite clearly, didn't it, with the differences in the data that was analysed. So it would be really, really good to take part in this, to really highlight that activity and the understanding of what isn't a GP's paid job.
Yeah,
I've forgotten the strapline
GPSU.
they call it, the GP just, isn't it? It's the the strapline is the GP can just. And anything that is attached to that, we want to hear.
Yeah. So we're going to work with Jenna on this, I think, and just make sure that everybody's got that information circulated in the next 2 to 3 weeks, I guess. So we're ready for January. Catherine Fitzpatrick is the lead on this for SFT as well. So she's very keen to get as much information as she can. So I think that's the main bits. Rather than talk too much, I mean, it'd be really interesting to see what questions people have about the pilot.
Karen and I could talk about this a lot. But it'd be quite interesting just to hear what, and any information that you would be interested to hear from us.
Any thoughts? Jenna, is there? Oh yeah, go for it.
I think Celia, is it Celia?
Yeah, no, I was just going to say that's great, because I was writing down a question and then you answered the question, which was, we all don't know what, I mean, obviously we've read the contract in and out, but we don't really know on a day-to-day basis, and it'd be great to have some crib sheets for reception, and they can do a 5-bar tally, I assume, because I also wonder how did staff feel about taking that information? Did they see it as one more thing that you're asking them to do? How did you manage it? Because, you know, I've done audits here, and it's you know, a little bit of eye rolling. Oh, that's something, you know, I want to just do the job. Yeah,
there definitely was eye rolling, but it really took some, for me, because our PCN is 5 practices, so it took quite a lot of, you know, some collaborative meetings and some reassurance, and a lot of this is unprecedented. You're part of a new thing, you know, a new audit that's going to improve our lives and your lives and the development. So there was a lot of sort of positive comms, and then we would set up every week. We did a drop-in session at the beginning of an audit week, the middle and the end of an audit week, and people could drop in and go, oh, I don't understand this, am I doing this right? And then at the end of the week there was always a point of collaboration with us and our data person, just to reassure that we understood what was being sent in. So it was really about communications and reassurance.
Okay, so it sounds like you'll have an amazing template you can just send out to practices, and we can just follow and learn from what you've done.
With the
and following on from Emma, I mean, we just bribed everybody. We just bought loads of fruit, loads of snacks, and said, there you go. That's a big thank you for filling out the forms. I think the thing I will say is that our GPs, and maybe this is the fact we're doing so much of the secondary care work, they were so desperate for this to be visible that I didn't get a single complaint. They were all on board really, really quickly. And we did communicate that and do similar things to Emma, but we just decided to bribe with food as well, because that normally gets through most things. Bribes,
prizes, a little bit of healthy competition between the practices on what levels of response we got. It took some legwork, but it wasn't, you know, it wasn't backbreaking. It was just a bit more time consuming, but the benefits are going to absolutely outweigh that it wasn't that arduous.
Well, if you get a win with the advice and guidance, you've got evidence that what you're doing is paying off, and that will help encourage.
And we've got some
join,
wins in the gaps in commissioning around our, you know, our heart failure and our hospital at home, and that's really coming to light. And we've got some work that we're able to do on that as well. And we got a bit of pressure on our second blood collections that weren't available to us in our areas, Freeman, our 5 practices, and it was kind of showing the need of that and the being able to report back on what improvements we've seen from putting those kind of things in place. So it has been worthwhile. I think the SFT teams sheet we've got, haven't we, which is already, you know, in place and built, and then any tally sheets that you would like to do, I'm sure we'd be able to help and provide those.
Thank
Gemma,
you.
Jenna, do you want to come in with your hands raised?
Yes, I was just going to add that I think the most important thing here is the data and the feedback fed back to our practices. So this form has been around for a while and has been used on and off, but the feedback we've been given is that there is no data or feedback being fed back to practices, which is why perhaps uptake of this form has slowed down. So that's why we decided that for a full month, just going full force at it to identify these themes, and then we can meet with secondary care, identify the themes, get some practice to feed back to our general practices, and come up with some plans for improvement, or meet with the ICB and look at the funding streams and things like Karen has said, just to make sure that practices are being funded for the work that they're doing, but also to highlight any niggly issues that can be fixed as well. So absolutely just use the form as much as you possibly can, or collate data as however you need to, as long as that can get back to us, then we can certainly do something with that data.
Were you
I think
going
the
to
really
show?
important thing to say is this is a really unique opportunity for us to also raise this at a national level and get some really significant change, and we have achieved that. I mean, I think the very first meeting that we had, we were the first one on the Tim Briggs and Claire Fuller tour, is we got that change in advice and guidance because we voiced how serious it was. I know people can often get a bit cynical about these things, but we've got another year of a voice that is listening where we can push for change. So, use our ability of being on the pilot to help, get everything better for Somerset. I mean, that's what we're here for. It's not just to get change for our PCNs. We want change across the board and nationally. And I think, this is such a good opportunity. And anybody who's been in a room with Claire Fuller and Tim Briggs, it's quite a brutal experience if you're on the receiving end, but they don't mess around. They just want stuff sorted, and they'll create the conditions for that change to happen in a way I've never seen before. So that's a real positive. So
it
please
is
engage.
And I think if there's if any of the CDs or appropriate people that would want to join that, it's a really unique opportunity where you've got NHS England, your CDs, your primary care, your secondary care, and ICB all in one room. It can be quite, I'm not going to say heated, it's constructive, and it's an environment that I've never been in before, where you've got all of those bodies in that room being very vocal about what they're doing. And I think it's also important to point that although Karen and I have focused on the secondary care interface side of things, I mean, we are trying to pull together as realistic a look at what primary care actually delivers on our day-to-day basis, not just with secondary care interface. It's about what we're doing day to day, and how that's affecting all the the capacity and access of our areas as well. So I mean, it's an amazing job that their digital team are doing, their analytics team, because it's a vast, quite overwhelming project. I mean, Gareth might want to offer some input there of what they're trying to align, but the commonalities in our data alone are going to be really, really hard to find, but we're getting there.
And I think the timing of the audit is really so that can collate the feedback and identify some themes and some specifics in time for the next meeting, isn't it?
Yeah.
Which is,
Yes, the next meeting will be in March, so that's when we'll be collating the next information for.
Great, thank you. Any other questions from anybody about that in particular? Thank you both. Oh, Jenna.
Yeah, it was just to say, yes, thank you for coming to present today. It's been really helpful, and at the CD board, but also just thank you for being the vehicle of helping us drive this forward and getting us to those meetings and having a collective voice. Appreciate that. Thank you.
Yeah, and if there's any CDs that want invites to the Claire Fullerton Briggs tour, and if we can accommodate in whichever venues then we're happy to kind of expand that invite as well.
Yeah, absolutely. And Emma and I are also really happy to answer any questions that you think of outside of this as well. So
great. So I think I can't quite see everybody who's in the meeting. That the next thing we were going to share with you was some of the conversations that Christoph and other CDs in South Somerset have been having about neighbourhood working. Christoph, are you there? Hi.
I am there. Yeah.
Hi. Welcome.
Hi.
Thank you so much.
Thank you. I was hoping to be at the next stop in the surgery, but I didn't quite make it because there was a road closure, so you have to put up with me in the car.
Annoying. That's fine.
But here we are. No, I'm here. Yeah. Would you want me to just say what was going on? Was it?
I think so. If you, bit of the, yes, basically the summary you gave.
So
this morning. Thank you.
Yeah. So we had, as 4 CDs of South Somerset, we had a meeting. It was in October where we wanted to discuss how we could potentially form a united approach. So along the lines of the new 10-year neighborhoods or the proposed neighborhoods. And we all felt that was, in our best interest. And therefore, then we called a meeting with the help of GPSU to have the wider discussion, which we had at early November with most of the surgeries in South Somerset, and discussed the feeling in the room, which was generally, I would say, supportive. We'll have a further meeting, coming up in December. The whole thing was the neighborhood was not to encroach on general practice, so we weren't trying to compete against the individual surgeries, but more to be the vehicle for the other contracts, other service provision that might be coming primary care way, and also to try and set up a better decision making model that we can't, because we felt it was all taking too long sometimes to get decisions made in terms of, you take it to the CD board, then it goes to the PCN board, possibly, then it goes to the partners, and then it gets fed up with the chain again. So we were thinking of perhaps having a slicker decision-making board in that way. So that's where we are, and James kindly started to write some terms of reference to get some ideas, and I put something in. We haven't shared actually with the other CDs in South Somerset yet, so it would be quite good perhaps to mail them as well, because I've forgotten to mail them to get their input. But that's where we are. And this morning we had, interestingly, a meeting, because as soon as it became public that we were looking at this, interesting, SFT and also the council wanted to meet. And we had a meeting this morning in Abbey Manor in Yeovil with Peter Lewis and I can't remember, there was a Duncan, is it? I can't remember the name now. Yeah, Duncan Sharkey from the council, and also from a representative from SASP. And I think generally we all feel that we would like to create a neighborhood. The problem is sometimes the terminology we felt. So neighborhoods are already oft talked about, but they're probably a different thing than the 10-year neighborhood, what we were talking about. But in the end, we all want to deliver services for patients in the community, and ideally primary care led. That was kind of the feeling. But how we go about it, I mean, there is a lot of in the small print when the contract finally come out. We will have to have a look. How does a left shift actually happen? We briefly raised one of the little projects we wanted to get off the ground, which was the heart failure project, and which requires potentially some decommissioning from secondary care into primary care, but the ICB finds that difficult for understandable reasons. Yeah, so that's where we are.
Thank you, Christoph. I just wondered if others have got any reflections on that, what you've heard from Christoph, or similar conversations. We're trying to enable or facilitate sessions or gettings together in other parts of the county to start to think about neighbourhood working. I think one of the big challenges we know we've got is that we're starting to talk contract and form really rather than function, which feels as though it's the wrong way round, but that's where we are. But the challenge is we don't yet have that contract, and so a lot of the actual detail isn't there, and yet it feels really important that we nonetheless start to be talking and thinking about what good might look like or better might look like, so that when the documentation does finally land, we've got we've already started to prepare ourselves for that. Barbara.
I suppose, Ruth, I just wanted to ask, obviously we're having discussions within Somerset and we've already started some of the discussions, but have you heard more generally, particularly within our cluster maybe, are there similar sort of discussions happening in general practice across the other counties, for example? Have you heard anything through your links with the other federations, etc.?
Yeah, I mean, certainly I know, I think Ruth was alluding to, I think West Somerset, Taunton, I think are talking to each other, but probably Ruth is better placed to say that. The other thing is, I mean, we know, and interesting came up this morning, further north, even just in Bristol, Gloucestershire way, but even further north in the Midlands, I think neighbourhoods or PCNs at the time were set up completely different than in Somerset, and they are far bigger entities. They're running far more community services. They are more like really big. So PCNs became federation, as far as I understand. So the multiple PCNs became federations, and they are big players, you can say, in some parts in the middle of England and northern England. But out down here, we don't really have it. I think the closest one, and Ruth is more the expert in that, is really the Bristol, Gloucestershire type area. But yes, I think the conversations are going on. If only we would have some clear instructions from the government, because it's sometimes difficult to plan and then only be told, oh, actually that's not what we wanted and you have to do it that way. I know this morning came up that they're trying to influence that they don't put any particularly structures in place from high up, but I mean, knowing from experience in the NHS over nearly 20 years, that doesn't seem to be like that ever. So, well, yeah.
Yeah, thank you. And those larger federated models in structure look very similar to SPH or the GPSU. I think the different layers of decision making might be considered or set up slightly differently, but there's no. I think that's what we want to understand as the GPSUs, is how could we enable some of the single or multi-neighbour contract conversations to be had with us, so that we can provide some sort of infrastructure, but difficult to do that until we really know the detail. And in the meantime, it's very important, I think, to be having those partner to partner, provider to provider conversations with the other players in our system. Interestingly, the Wiltshire practices and the Dorset practices don't have a federation, and I'm referring to us as a federation because that's nationally that's the sort of term that people would use looking at us from outside. They don't have that sort of structure, so are wanting to talk to us about how we could, well, how we're working, what our vision could be, and how we could potentially partner. You have got in Baines, there is an organisation called BEMS, which grew up out of the co-ops set up post 2004. I think they're Baines Emergency Medical Services is their name, but they refer to themselves as BEMS. So there is something there, and Swindon has got a fairly recently established federation. So across the cluster, it's a very mixed picture. And I think there is something about us not looking in isolation at Somerset, because there might be some efficiency if we are being funded by the ICB for our core funding. You just wonder what that might look like now we're in a cluster and how that might be reduced or not. So I think we need to keep alive to all these different changes going on around us, but with our eye on Somerset and our population. So it's a lot of uncertainty, but I think with the uncertainty, there is an opportunity to start to shape and influence through the right relationships and conversations, like the one Christoph and the team had with SFT and the local authority today. I thought it was a really good start to conversations. Yeah.
Yeah, no, I think it was certainly good. I'm always worried with these things. You know, are we still moving forward? I mean, will there be anything coming from this? So it's not just a talking shop in the end. You know, that's it needs to have some direction and some movement in it, because otherwise it's not worth it.
So, any other questions or thoughts that have been provoked by what you've heard from Christoph? Or is there anything else? We've just got a few minutes left that James or Barbara, you think it's worth sharing before we drop off the call?
Can I just mention the clinical reference group, if I may? You mentioned it briefly. So as Ruth said, we have set up a clinical reference group. So it's a group of GPs, nurses and pharmacists, so clinicians, clinical. We've been tasked to look at some clinical pathways within our system. We are looking at the NFF document. So at the moment, we're looking at celiac disease, for example. That was a nice one to get our sort of teeth into and look at that pathway, and we will be in January discussing with the gastro team and dietetics team in SFT the pathway. But I just wanted to make you aware that obviously if you have any conversations or if there are really pathways that you think don't work, and we're really super keen that we actually get some requests and information from general practice if there's something that's not working or you want us to review as a group. We have a pro forma you just have to fill out just so that we can keep track of all the requests that are coming in. We'd be delighted to, you know, review and consider a pathway if you think it's not working for general practice. That's what we're here to do. But essentially I just wanted to say that we are now live and functioning, and and obviously any sort of queries or any thoughts, or if you want to know more about the CRG, please do contact myself or the GPSU admin inbox. Certainly happy to ask any questions, or if you've got any thoughts about a pathway, please let us know and we will absolutely consider it.
Thanks,
That
Barbara.
was my little. Thank you.
Thank you. And James?
I was just going to add that as those on the call will recognise, we are an ever-growing team. So there's a number of new members of the team that have joined in recent weeks, and it does mean that a lot of this work that previously was on the to-do list, but we never necessarily had the capacity to get some of this done, we can now pick this up on your behalf. So the work that Jenna's going to do with regards to that primary care, secondary care interface is a really good example. And Christoph with the neighbourhoods, historically, these conversations might have stagnated, but now we have the capacity and expertise to keep them going on your behalf. So we're really pleased to welcome a number of members to the team.
And do you want to just briefly mention the Optum comms that has gone out?
Yes, so you may have seen there was I sent an expression of interest template out to PCN managers and clinical directors on Monday of this week around the opportunity to take part in a pilot with Optum. So we're going to be procuring their Pathfinder tool, and up to 3 PCNs will be chosen to work with ourselves and Optum and just really dive into population health management. It's something that we know we want to be at the forefront of and have been talking about for a long time, and we'll now have the capacity and expertise to really delve into that, looking specifically at those with moderate to severe frailty, looking at redesigning care pathways, doing things more effectively, and hopefully demonstrating, again, an output of this work might be that primary care or secondary care to primary care shift that we can demonstrate. So be a lot of data analysis. So we're really keen to, as the GPSU, to get involved in population health management. So it's a big step for us, but also for hopefully 2 or 3 PCNs to be involved in as well. There is a drop-in session on Monday at midday for anyone who wishes to join. Just let me know and I'll forward the invite.
Thanks, James. Thank you. Any questions from anybody before we give you a couple of minutes back from lunchtime? Thank you so much for joining us. Hope you found this useful. And if you've got ideas about how we could, for a different time of day or different day of the week or a different format, please give us some feedback, because then that can help us make sure we're doing the right thing. Thank you all very much.
Thank you.
Thanks, everyone.
Thank you. Bye. And thanks, Karen, Christoph and Emma. Thank you.